I want to thank the organizers for the invitation and the opportunity to reflect on stagnant cervical cancer mortality. I'm Diana Buist. I'm an epidemiologist and a health services researcher at Kaiser Permanente, Washington Health Research. My disclosures are noted here, and just wanted to comment that I am doing some research on self-testing, and we'll be talking about that. I believe it's possible to eradicate cervical cancer, and I'm not alone. As touched on by Dr. Wheeler, the WHO has a clearly articulated cervical cancer eradication global strategy, which will also reduce the global burden of other HPV-related cancers. WHO's strategy includes prevention, high-performance testing, and receipt of appropriate treatment. And it's bold, but it could be within reach. These pillars, plus education, are going to be needed to move stagnant cervical cancer mortality rates. There is a clear opportunity to improve access to proven prevention. There is a threefold difference in HPV vaccination rates between low and high income countries. We see the same patterns in high income countries with vaccine rates dependent on income and location. The growing divide in vaccination and screening will continue to perpetuate cervical cancer disparities across the globe. Researching how to increase vaccine uptake in varied settings and populations and to improve screening uptake in unscreened individuals will have the greatest impact on cervical cancer mortality. A one-size-fits-all strategy will not meet the local context and the vastly different cultures, and will therefore require significant local efforts. Eradication is necessarily going to require a global focus, and therefore it's going to be critical for NIH to purposefully grapple with how cervical cancer research funding should be allocated to US-focused research versus other parts of the globe. Mandating vaccines as a public health policy has a long history in the United States, which invariably creates tension between public health policy and individual rights. There must be public health benefit for mandating vaccines. These are typically limited to viruses that spread in age groups for which the vaccine is mandated, and when the disease can effectively be controlled only by vaccinating a high proportion of the population. Vaccines should also be low risk and have high benefit. The Advisory Committee on Immunization Practices recommends HPV vaccination, a vaccine that costs $35,000 per quality adjusted life year. What's challenging for HPV vaccines is that it targets a virus that causes cancer far in the future, as Dr. Wheeler just commented on. And this is very different from any mandated vaccine, which focuses on viruses that cause immediate harm, like COVID and measles. An important opportunity has arisen from COVID that may allow individuals to better understand the role HPV vaccinations play in prevention with a much better understanding of R0 and herd immunity. This makes it an important time for additional education about the benefits and harms of HPV vaccines. For prevention, the greatest potential for eradicating cervical cancer will be spending our limited research dollars on getting shots in arms, a familiar COVID term, versus additional research on further improving an already effective vaccine. With the hopes of other cancer prevention vaccines in the future, like Hep B, it may be time to reevaluate vaccine mandates that result in public benefit in cases where viral transmission has a long sojourn time. Next, I want to discuss screening. There are roughly 73 million females aged 30 to 64 with an intact uterus who are recommended to receive cervical cancer screening. I'm not mentioning the 20 to 29-year-old females here because they don't represent the largest burden of cervical cancer incidence and mortality. Among those 73 million females, 18.3 million are not up to date for cervical cancer screening, which I will refer to as underscreened. And there are 14,000 cervical cancer cases diagnosed annually in the United States. 50% of these cases are diagnosed in underscreened females. Increasing screening in underscreened females is going to be critical to reduce cervical cancer mortality. So why don't people get screened? There have been decades of research focused on this specific issues, which have consistent findings. This word cloud shows the rough contribution of patient-reported barriers and depicts the important role of several factors associated with access, patient concerns around fear and body image, and cervical cancer knowledge. I'm going to touch on these factors next. Let me start with access. With a disjointed healthcare system, as Dr. Wheeler mentioned, Access is an issue. The Affordable Care Act reduced screening barriers through providing a $0 coverage for cervical cancer screening. However, this really hasn't changed screening rates. If anything, they appear to be decreasing. Some aspects of access and patient concerns around fear, body image, and sexual trauma could be addressed by self-testing. This is not a new idea. In fact, Australia, the Netherlands, Malaysia, and Denmark have been testing self-sampling strategies for years. Meta-analysis of several observational studies and screening trials have reported self-sampling sensitivity compared to cytology and comparable sensitivity to clinician-collected PCR-based HPV testing. Yet there are no HPV self-sampling strategies that have been approved by the FDA to use in clinical care or as an alternative screening approach for females who do not or cannot access clinic-based or speculum exams, despite resounding international evidence supporting their effectiveness. Dr. Rachel Weiner and I conducted a pragmatic randomized trial in Kaiser Permanente, Washington, evaluating self-collection in just under 20,000 underscreened females. We sent vaginal self-collection HPV kits to half of these females and compared screening uptake over 6 months in the intervention arm compared to the usual care arm. Importantly, at the time of this trial, primary HPV screening was not recommended and self-collection was not FDA approved. Therefore, everyone was still recommended to receive in-person screening. You can see from our results here that the uptake in both arms remained low, illustrating that even in a system where people have access and coverage, it's hard to get underscreened individuals to come in for screening. Sending self-collection kits that were returned to our lab and managed by our healthcare system resulted in a 50% increase in screening. However, because vaginal HPV sampling does not allow for reflex cytology from the same sample, it's important to understand screening failures that can arise from home testing when individuals with HPV positive results do not return to the clinic. In our trial, we observed that 3 out of 100 females needed to come in for a colposcopy because they were 16-18 positive, and 8.5 out of 100 needed to come in to the clinic for a PAP. Test performance of any screening strategy is heavily influenced by the follow-up of abnormal results, and follow-up protocols in cervical cancer screening are increasingly complex, as Dr. Wheeler pointed out. All testing strategies require systems that can follow positive results for individuals with appropriate care, particularly since these are the individuals that are at the highest risk for cancer. This may be a greater challenge for home testing that occurs outside clinical systems and will require research to ensure appropriate follow-up. We did one-on-one and more in-depth interview surveys to better understand patient experiences, which was critical to understanding the trial outcomes versus relying on electronic data alone. Patients liked the home test and most would do it again, but discordant results from self-collection and in-clinic cytology samples were confusing to patients. Younger vaccinated individuals don't understand why they still need to be screened, and this is a growing population where education and outreach is still needed. Surprisingly, older females were more likely to do the self-collection compared to younger females, but were surprised when they tested HPV positive when they reported being monogamous or not sexually active. We need to figure out how to communicate complex messages, and these efforts are likely going to require developing and testing age and culturally appropriate materials. This could benefit from funding opportunities linking scientists with business and marketing teams, much like what was done for NIH's All of Us initiative. Now to address knowledge. We're in the process of conducting a second pragmatic trial in Kaiser Permanente, Washington with 30,000 females with varied prior screening behavior and are testing different screening outreach strategies. We are also conducting a trial within a trial that is focused on assessing the impact of age-tailored education materials. I want to touch on FDA approval being a barrier to self-collection. There's great interest in accelerating screening through self-collection internationally. This is an opportune time to learn something from our current pandemic. I've highlighted the article by Tu et al. Here as an example of how laboratories rapidly tested assays and platforms for COVID testing, which were implemented into practice globally. Why can't we move faster to do the same thing for home testing? I want to return to another issue that addresses stagnant cervical cancer mortality, particularly specific to the US context. Rapidly evolving cancer screening and cervical surveillance recommendations can be complicated, not just to patients, but to entire healthcare systems. Dr. Taplin and NCI colleagues outlined multi-level factors influencing cancer screening and outcomes, which demonstrates there are a lot of factors at many levels that influence outcomes. Ensuring some research is done in systems with additional supporting factors such as insurance and coordinated care can be critical to shed light where systems fail, even in the presence of a lot of supporting factors. But it goes without saying that these failures may not be the same in populations with more fractured care. We simply cannot expect the same barriers and facilitators will exist in different settings, within and outside the US. NCIs continue to invest in multi-site cervical cancer screening through a UM1 collaboration across multiple sites, and investments like these will ensure that there is distribution of location and context for multi-level studies, and that will be critical. So my recommendations are the following. The first is learn from COVID. I want to talk about specific recommendations focused on primary prevention and education, self-collection in terms of validation and implementation, and speed. And see below regarding NIH. We have figured out in the past almost 2 years how to do things in ways that we have never done it before. And this is really important for all of what we're talking about today. Multi-level everything. And I just want to comment that what I mean by this is multi-level studies, multi-site, multi-modalities that include mixed methods, multilingual, and multicultural. Mechanisms that enable these types of studies with adequate funding are going to be critical. And it's really important that we don't limit our evaluations just to electronic medical records. Invest in training, and this is for researchers to communicate to various stakeholders. And while there's been a significant improvement in these areas, there is a long way to go. This isn't just about communicating, it's about ensuring our research is translated in ways that are meaningful for policymakers, health systems, and patients. And finally, I want to talk about just a small thing, which is my suggestion to reform NIH funding paradigm. It just takes too long to get grants written, reviewed, funded, not to mention getting them into the field. And if we want to do more meaningful work to change outcomes, we must move faster. There are some really exciting, innovative grant mechanisms that allow for more rapid plan, do, check, and act and modify, including things like UG3 and UH3 mechanisms, and then also small R01 grants for randomized trials such as PAR 20-160. And I want to just recommend that we really consider that these things be looked at very carefully in terms of being able to move the paradigm forward. And finally, I just want to say thank you. And again, thank you to the organizers.